Alhamdulillah, to get the program started with the Quranic ayat, inshallah, I'll invite Hafiz Rayhan Ahmed to do a few ayats of Quran, and followed by Rayhan Ahmed, Hafiz Rayhan Ahmed, to do the translation, inshallah.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم وإذ قال إبراهيم لأبيه آزر أتتخذ أصناما آلهة إني أراك وقومك في ضلال مبين وكذلك نري إبراهيم ملكوت السماوات والأرض وليكون من الموقنين فلما جن عليه الليل رأى كوكبا قال هذا ربي فلما أفل قال لا أحب الآفلين فلما رأى القمر بازغا قال هذا ربي فلما أفل قال لئن لم يهدني ربي لأكونن من القوم الضالين فلما رأى الشمس بازغة قال هذا ربي هذا أكبر فلما أفلت قال يا قوم إني بريء مما تشركون إني وجهت وجهي للذي فطر السماوات والأرض حنيفا وما أنا من المشركين صدق الله العظيم.
جزاك الله خير. Thank you so much, Hafiz Rayhan. And I would invite Hafiz Rayhan to come and do the translation, please.
Assalamu alaikum wa rahmatullah. And remember when Ibrahim alayhi salam said to his father Azar, do you take idols as gods? It is clear to me that you and your people are entirely misguided. We also showed Ibrahim the wonders of the heavens and the earth, so he would be sure in his faith. When the night grew dark upon him, he saw a star and said, this is my Lord. But when it set, he said, I do not love things that set. Then when he saw the moon rising, he said, this one is my Lord. But when it disappeared, he said, if my Lord does not guide me, I will certainly be one of the misguided people. Then when he saw the sun shining, he said, this must be my Lord. It is the greatest. But when again it set, he declared, O my people, I totally reject whatever you associate with Allah in worship. I have turned my face towards the one who has originated the heavens and the earth, being upright, and I am not one of the polytheists. Jazakallah khair.
Jazakallah khair, Hafiz Rayhan. So on behalf of Healthcare Committee from MCC, I, Dr. Farooq Ahmed, Dr. Umar, and Dr. Afreen, we all the team. We welcome all you guests. Thank you so much for coming and making this a successful program. MashaAllah, it's a good attendance. And on top of it, I will welcome Dr. Jalal Baig and Dr. Samir Alvi, both are cancer specialists. Dr. Baig is an oncologist and a clinical associate professor at University of Chicago. And Dr. Baig is also a freelance writer. He has worked on healthcare and Muslim identity. He had appeared on Washington Post, CNN, MSNBC, NPR, and elsewhere else too. And Dr. Samir Alvi, he's also Director of Head and Neck Cancer Surgery at Endeavor Health and Clinical Assistant Professor at the University of Chicago. We all welcome you, doctors. Thank you so much. So get the program started. I would request Dr. Dr. Jalal Baig to get started, inshallah. Jazakallah khair.
Hello? Oh, assalamu alaikum. So an important part of my biography in terms of credibility in the community is I'm also the coach of the second grade boys team in MCCA. So that's my big community connection. So thank you to the Health and Awareness Committee for the opportunity. It's a privilege to be here with Dr. Samir Alvi. a privilege to have this platform in front of the community. My name is Jalal Baig. I'm a medical oncologist and hematologist. I think it's important to define what an oncologist actually is. So in the large healthcare team that takes care of cancer, I'm the person that sometimes diagnoses the cancer, but more importantly, the person that's making the decision in terms of what treatments are required, whether it's chemotherapy, immunotherapy, or sometimes targeted therapy. In other cases, making referrals to the radiation oncologist for radiation treatments, or sometimes referring to a surgical oncologist. And in that domain would be Dr. Alvi, if someone has a head and neck cancer, and I think it's relevant that the patient has an evaluation for surgery, Dr. Samir Alvi would be someone I would refer to. And I'm at the University of Chicago, specifically at the Cancer Center in Ascension St. Joseph in Lincoln Park. So I'll go ahead and jump right in. I was going to provide an outline, but when I started putting the talk together, it sort of seemed so scattered, and there wasn't anything coherent that I could put in an outline, so just bear with me as we kind of navigate this through. One thing that I wanted to pay special attention to is the context of the time that we're in and why certain things are so important. And we are living in a time, especially in this country, where science is under attack at some of the highest levels, whether it's from the CDC, the current Trump administration. We're getting misinformation, disinformation on social media, a lot of AI-generated content, and a lot of WhatsApp content. A lot of aunties and uncles are constantly forwarding stuff to me and saying, is this true? Did they find the cure for cancer and they're hiding it from us? So stuff of that nature. So always be a little skeptical and suspicious of what you're seeing, whether it's on Facebook, on Instagram, what may look fake to you in terms of AI generation, and then most importantly, WhatsApp. And there's a heightened need for responsibility on what we consume and what we share to other individuals. We see a lot of this in the news, whether it was the recent banning of the hepatitis B vaccination for newborns, whether it's a recommendation that Tylenol should not be given to pregnant women, and other things that we talk about, such as another topic that's reemerged in terms of the connection between vaccines and autism. There was one specific line that I read just in an article a couple days ago that I felt was pertinent, so I provided it here. But conspiratorial thinking is fueled by the inverse, self-assured conjecture that demands a level of refutation that no amount of evidence can offer. The language of science is measured and provisional. The language of politics is declarative and bombastic. So before I jump into cancer screening and why it's important, I think it's good to step away. I'm no Islamic scholar by any means. But while I was researching this topic, I felt there were certain parts of it that I came across that I felt I should share. Specifically, what I felt was a pretty authentic and remarkable hadith from the Prophet when he said that your body has a right over you. And why did I feel that's important? Because it basically implies that our bodies have a rightful claim against us. There is a lot of fatalism and predetermination that exists in Islam, and a lot of people subscribe to that. And I felt this specific hadith kind of counters that and tells you to take control and gives you agency to take control of your own health. And it kind of makes it an obligation to protect your body against harm, take any precautions against subjecting it to illness, provide it with necessary treatment when it suffers from specific disease. And then one other hadith that had some relevance, second to faith, no one has ever been given a greater blessing than health. And its preservation and its protection, I think, are paramount for us. So on this topic of Muslims and cancer screenings, a whole host of work and research has been done. Just a quick Google search or even a PubMed search for people that are looking for more credible sources will find plenty of data that's been done that studied the Muslim American population, trying to figure out what our cancer screening rates are compared to the general population. Some of the cancers that exist that we do have cancer screening methods for are breast cancer, lung cancer, prostate cancer, cervical cancer, and colon cancer being the other most important one. So a lot of these studies have looked at to see how do Muslims what's the percentage of Muslims that actually get age-appropriate screenings compared to the general population? Some of these studies have looked at Arab Muslim women. Some of these have looked at urban Muslim populations in Washington, D.C., and even Chicago. Chicago's Muslim American population has been studied to see how do our rates and what are the barriers if certain cancers screenings are not done at the rates that are appropriate. What are the barriers and what's preventing Muslim Americans from getting their cancer screenings done? I didn't want to go into all the specifics because there's so many different studies that exist. So I just wanted to distill it down to what's actually appropriate and pertinent. So across all of these studies, I found some common themes. So the data shows that screening rates amongst Muslim American populations are lower than the general population when it comes to mammograms, which are used for breast cancer screening, pap smears for cervical cancer screening, and colonoscopies, which are used for colon cancer screenings. A lot of the screening barriers per the people that did these studies include modesty concerns, absence of same-gender providers, this belief in fatalism or predetermination that Allah had already preordained that I'm going to get cancer. What's the point of me even getting screening done? Sometimes lower English proficiency, sometimes lower healthcare IQ, and a lack of access, whether that's insurance or whether that's just a lack of access to a primary healthcare clinic. Interestingly enough, there have been some interventions. One of those interventions was done in 2018, and one of the study was piloted at MEC. So there were two populations that were done in Chicago, and one of those populations was at MEC. This was a study that's located at the bottom of this page that looked at how can we help improve the mammogram rates amongst Muslim women, specifically having a more religiously tailored narrative to try to encourage these women who have modesty concerns, gender concerns, etc., to try to rectify those and improve mammogram rates amongst Muslim American women. One of the people that's foremost and prominent in doing these studies was Dr. Asim Padilla. He's an emergency medicine doctor. He practices in Milwaukee currently, and he focuses on the intersection of multiple parts of healthcare, whether it's Islam, public health, and cancer screenings. And so he's done a lot of important work on that. And this one specific study that, like I said, was piloted also at MEC looked at 58 Muslim women who were over the age of 80, and they participated in 2 half-day mosque-based classes. And one of those mosques was MEC. None of these women had mammograms done in the past 2 years. And as we'll get to later on, we'll see that these women were well overdue because mammogram screenings can begin at 40 or even 45, and sometimes based on a woman's family history can begin even prior to 40. So a lot of these women were over 50, had never had mammograms in the previous 2 years. And the study sought to find out how can we help this issue? How can we make these women more comfortable? So classes were given, and in these classes there were female peer educators from 2 different communities, both South Asian and Arab communities, and these were trained by Dr. Padilla's team, who was at University of Chicago at the time. So in addition to those female peer educators, there were other individuals, a religious scholar, a breast cancer surgeon, and also a community health expert that also participated in these talks to try to increase the comfort and education amongst these women. So the goal was these religiously tailored messages to motivate behavior change and address these religious concerns or reservations that these women had about mammography. And a lot of these women had this belief that breast cancer screening is not important because God will decide who will get cancer. And regardless of what these Muslim women felt they could do, it was already preordained. So again, that fatalism and belief that this was preordained and there's no intervention that I can do on my part to prevent this, that was countered and combated, discussing the idea that although God controls disease and illness, it is my religious responsibility to take care of my body and get cancer screening. So again, going back to that one initial hadith that we talked about, that you have a right, your body has a right over you. You have an obligation to take care of your body. And of the 48 participants, 20 obtained a mammogram by the 6-month follow-up, and another 2 did so at the 1-year mark. So again, showing some benefit to these interventions. And again, this is a topic for another day, but this is something I wanted to shed light on just to kind of show the enormity of the challenge that we have sometimes to get our Muslim populations to obtain what are generally recommended screenings for the population. Before we get to screenings, I just wanted to make note of one specific phenomenon that I'm seeing in the clinic. We've seen it also occur in the community as well. One of the primary things that motivated and inspired and kind of hatched this talk for both me and Dr. Alvi was that we had some cases in the community of head and neck cancers recently, and some cancers in patients who are close to 50 and earlier than 50. Then that kind of inspired us that perhaps this is a timely talk to discuss with amongst the community, both our elderly aging population, but also younger patients. And for those that are paying attention to mainstream media, whether it's the New York Times, CNN, I picked up two titles that have been in the news over the last couple of years. Whether it's people who are younger than others that are getting colon cancer, which is one headline that I pasted over here. And then another one from CNN that cancer incidence is rising amongst people under than 50. And it's kind of befuddling a lot of doctors right now, leaving us confused as to why this phenomenon is occurring. And a lot of work is happening, but I at least wanted to bring to light this phenomenon and the little bit that we can do to at least make ourselves aware of it and also help younger patients advocate for themselves in front of their doctors. So early onset cancers are defined as cancers occurring in individuals less than the age of 50. So a lot of studies are showing that these can be any types of cancers, whether it's colorectal cancer, breast cancer, uterine cancer, kidney cancer, pancreatic cancer, multiple myeloma, which is a kind of blood cancer. And these are occurring at higher incidence rates compared to individuals at later ages. And these are occurring in countries that are of high socioeconomic development, whether it's the United States, United Kingdom, Australia, or New Zealand. Some people have kind of posited the hypothesis that this might be just due to increased screening. And this could be true for some of those cancers, whether it's thyroid cancer or maybe prostate cancer. Some countries are doing ultrasounds on thyroids, or they're checking PSAs and doing prostate biopsies pretty frequently. So some of the fact that we're finding more cancers in younger people could just be because we're looking for it more often, specifically in thyroid cancers and prostate cancers. But there are certain cancers, at least colorectal cancer and uterine cancer, which not only are showing up in higher numbers, but the mortality is also higher. So not only are we finding higher numbers in people that are less than 50, but people less than 50 are also dying from it in higher numbers, which shows that there's something to this phenomenon, especially for these cancers and potentially other ones. So why is this happening? And I think that's the most frightening question that exists right now, and we don't have all the answers, because in terms of genetics, we like to believe that your DNA and what your basic DNA composition is might be contributing to what's causing cancer. But the genetic risks haven't really increased if you look at someone who was born from the 1980s to the 1990s. Some of our population falls in that category. So genetically, nothing's really changed. So what really makes you concerned is that the environment and the lifestyle that we have. And in that environment and in that lifestyle, there's some very easily identifiable culprits, whether it's ultra-processed foods, sugary drinks like soda, red meat consumption, smoking, alcohol, sleep alterations, obesity, physical inactivity, and then changes in the gut microbiome being a lot of the bacteria that exists within our colon that helps in terms of immunity, helps in terms of digestion, and it can be altered. If you're eating trash, your gut microbiome can change. If you're eating some certain medications or you're taking an excess of antibiotics, your gut microbiome or the bacteria that exist can be altered, and they can kind of put you on an accelerated pathway to forming colon cancer at a younger age. And microplastics, so that's another environmental phenomenon that exists that could be contributing. So the picture that I'm painting right now, you might think, wow, I'm not that person. I don't eat McDonald's. I don't drink soda 3 times a day. I'm not fat. I exercise. But even patients that are extremely health conscious and exercising and eating well, I've seen these individuals, these marathon runners, who are in my clinic, and I'm diagnosing them with these cancers. Not only do I read about these in articles, but I'm seeing it with my own eyes in the clinic. And so obesity and lifestyle alone cannot account for all the young patients that are being diagnosed. Many of the patients that I'm treating, they're eating judiciously, they exercise regularly. So whatever is causing their specific cancers kind of still remains beyond our grasp. And that's why that there's this heightened panic right now amongst doctors and scientists to figure out why is this occurring at such a young age. And so I think the take-home message from all this, and that's what I want to emphasize, especially for these early onset cancers, and we've had some of these cases in our own community, is the awareness that this is occurring. A lot of times when you're very young and you have unexpected weight loss, you have blood in your stool, your appetite's changing, your stool is changing, you find a lump in your breast. If you're 35 years old, you're 42 years old, you're just gonna brush it off most of the time because you're gonna say, well, I'm super young, this isn't supposed to happen to me. And oftentimes you'll even go to your primary care doctor or you'll go to an urgent care and you'll say, well, you know, I've been noticing this blood in my stool every time I'm washing or I'm wiping, even though you shouldn't be wiping if you're Muslim, obviously. But you're washing, but you're noticing these things, and a lot of the times the primary care will just brush it off too, and will just say, it's not a big deal, you're young, I don't think this is anything concerning. And a lot of times this will fester, whether for 2 months, 3 months, and then you're at 6 months, where you've all of a sudden lost 30 pounds, this mass in your breast is larger, you're not only having blood in your stool, but now you're having rectal pain, you're having pain with your bowel movements and things like that. And then all of a sudden you get a colonoscopy or get a CT scan or you get a mammogram and all of a sudden there's a mass in your breast and you get a biopsy and there's a breast cancer there or there's a rectal cancer there. So the biggest thing that I can recommend to you is if these things are occurring, and especially if you're younger, you need to advocate for yourself. You'll Google stuff and whatnot, but you have to go to your primary care doctor and you have to say, you know, doctor, this is serious, this has been happening for a few months, I don't want you to brush this off. And so not only do we need more awareness at the primary care level that this phenomenon is happening, but patients need to advocate for themselves and tell the doctor that, can I get that colonoscopy, can I get that CT scan, can I get my blood work, please don't brush this off. And so be aware of your symptoms, talk about your symptoms with a healthcare professional, and also most importantly, be aware of your family history. If there was a first-degree relative, whether it was your mom or your dad or a brother or a sister or a cousin, an aunt or an uncle who was diagnosed with cancer, or you have a number of relatives who are diagnosed with cancer, you want to be aware of that, and that's very relevant. So not only if you're having symptoms, but you have a family history of colon cancer, a family history of breast cancer, that just sometimes adds to the urgency that you should get that mammogram a little bit sooner, or maybe you should get that colonoscopy a little bit sooner. Finally gets us to our last slide, cancer screening recommendations. So there's a handout that's on the table in front of all of you, which is basically the big take-home message. I've been talking for all this period of time to kind of fill time, I guess. But the take-home message is going to be the cancer screening recommendations. What's appropriate and when do you initiate these things at what specific ages? So cervical cancer is the first one that's relevant for women that are especially young, starting at the age of 25 and sometimes existing all the way to the age of 65. So the cervix is a canal that exists between the uterus and the vagina. It's specifically for female anatomy and for female patients, that's important. And a lot of these cervical cancer screening recommendations start at the age of 25. Whether it's HPV testing, whether it's a pap smear, depending on whatever is done, something should be done and initiated at the age of 25. Then we get to the next age bracket, which is 40 to 49. And that's where a lot more cancers come into play in terms of getting your screening done. Cervical cancer screening should already have been initiated before. It continues in this age between 40 and 49. Next is breast cancer screening and these mammograms, which are essentially an x-ray of the breast, sometimes also including a mammogram, sometimes also, including an ultrasound or an MRI of the breast. Specifically, women have an especially dense breast tissue. And so these mammograms begin at the age of 40, sometimes earlier based on a woman's family history, and they can continue all the way to whatever, maybe 65, 70, 75, as long as a woman has at least 10 more years left to live based on their relevant history at that time, they'll continue those cancer screenings for breasts. And sometimes these can be yearly mammograms, every 2 years. It's based on the findings, and sometimes this can be 6 months, but you at least need to initiate it by the age of 40, and sometimes sooner, like I said, based on family history. The big one here, and the one that's making all the headlines, is colorectal cancer screening, the dreaded colonoscopy. So that used to be at the age of 50, and that's been moved, that was moved down to the age of 45 in 2018. So this is the colonoscopy. I'm sure many people are aware of it and have had it. And that can now start all the way at the age of 45. And these early onset colon cancers kind of begin in the early 40s. So that's a pretty good age to start screening initiation. There's a whole debate on whether you can start earlier, and there's a lot of big debate whether on efficacy and resource utilization and things like that. A lot of public health discussion that's going on. But 45 is that age, and sometimes sooner based on your family history. And for colorectal screening, it doesn't always have to be visualization with a colonoscopy. It can also be stool testing methods as well. So you talk to your primary care doctor, your GI doctor, on alternative methods if you're not completely comfortable with getting a colonoscopy. Alternatives do exist. And also prostate cancer screening can begin in the mid-40s. That's more so for African Americans, but sometimes can begin in the 40s. But prostate cancer screening becomes more relevant sometimes at 50, where men are getting their PSA levels checked to detect to see if there's an elevation and if there's a need for a prostate biopsy. Colorectal cancer screening continues in this age of 50 plus. Breast cancer screening continues. Cervical cancer screening continues at this age. Cervical cancer screening can continue until 65. Colorectal can continue until 75. Breast cancer can continue until 75, even 80. Prostate cancer screening can also continue until about 70, 75. So this was in the news recently with Joe Biden's diagnosis at a late age. There was a lot of discussion on why was it missed, especially at a very high-grade metastatic prostate cancer. But it seems like he opted against prostate cancer screening when he reached a certain age. And then finally, lung cancer screening. That also begins at the age of 50. And that's most relevant for smokers, people who are smoking or have a smoking history even if they've quit. And specifically for people that have a 20-pack year smoking history. By 20-pack year, I mean people who've been smoking 1 pack a day for 20 years. So that's one definition of 20-pack year. Another is if you've been smoking 2 packs a day for up to 10 years. That also qualifies in that 20-pack year history. And the lung cancer screening is a low-dose CT. And for a lot of people that are smokers, this is one modality that exists, one method of cancer screening that should be taken advantage of. So this is a very broad topic, and I know that there are a lot of subtleties and nuances and whole different areas of cancer that can be discussed, and I think those are topics for another day. This was more of a sampling of putting out, I think, what are some really relevant issues that are pressing and hot in cancer right now, whether it's early onset cancers, cancer screening, some of the barriers that exist to just routine screening for Muslim populations. And there are people that are much smarter than me and much more qualified than me that can come and talk about some of those topics, like Dr. Ahsan Padilla, who worked here and did some of his cancer studies. I know my mother-in-law, Silva Danti, worked with Dr. Ahsan Padilla on this back in 2018. So our community is rich with a lot of gifted and talented people in healthcare that can come and shed some light on some of these topics. One of the brothers reached out to me on a group text before and said, would you be comfortable talking about this in smaller groups? Sometimes cancer is a very private, confidential type of topic, and people don't want to discuss it in larger group settings such as this. And he said, would you and Samir be comfortable maybe coming to someone's home? We'll cook biryani for you. We'll make it very interesting for you. But we'll have you come to your house. If you can come to one of our houses and smaller group discussions, people just may open up a little bit more. So if there's some interest in that, we'd definitely be open to that. My contact information, I'm on a lot of the parent WhatsApp groups. If anyone ever has any cancer-related questions or anything, my cell phone or email address is readily available. Happy to help whether it's a diagnosis or just any general questions. And there's a Q&A to follow after Samir is done. But then I think there's some food or something now, so I won't hold you so you guys can continue with that. But thank you so much.
MashaAllah, just such a beautiful, very concise and very important topics that you have touched, Dr. Dr. Jalal. Thank you so much for that. Quick question to Dr. Jalal is, I know you have mentioned the screening age going a little more earlier onset, like 45 years for colon cancer. What do you think about anybody has a family history of any of those cancers?
Yeah. No, that's an important topic, and we kind of touched on this. So knowing your family history is extremely essential, because that just means the age that you initiate your cancer screening can begin much sooner. It can begin even as early as 25, 30, 35. So knowing, especially your first-degree relatives, your parents, your siblings, your cousins, your aunts and uncles, knowing who had cancer, if they had cancer, and what age specifically their cancer was diagnosed has a lot of relevance and pertinence for you if you fall in that category, because the sooner you start screening, they might catch something sooner. So definitely very important.
This is very important, Jazakallah khair. So the sooner there's been catch-up, you can easy to treat and does prevent any complications afterwards, right?
Yeah, so the whole goal with screening is catching something before it becomes cancerous, so a precancerous polyp, if we're talking about colon cancer, or we're talking about a DCIS, so a cancer 0 in the breast. So catching something either before it becomes a cancer or catching something when it's a very early stage cancer, because inshallah, if something is still caught early, it's still very, very treatable. And I think we can't emphasize that enough. Cancer is very scary. And one other part that I just wanted to add, I know I talked about early onset cancers and I don't want to spook anybody. Those are still very, very rare that people less than 50 are getting cancers. Relatively, it's still very rare. But I just wanted people to be aware that it is happening, and if you have symptoms, you need to see a primary care doctor, you need to advocate for yourself and take it seriously.
Jazakallah khair. I know Q&A is coming up. We have a break for about 5 to 7 minutes. During that break, please help yourself. There are some burgers, some snacks, some fruits in the back. Come back, and if you have any Q&A questions, please write down on the card. And we have a whole Q&A sessions after Dr. Samir's talk, inshallah. If you have any further questions, please use a notepad and a pen to write down. We can address those questions and answers, inshallah. Inshallah, we're starting the program. I welcome Dr. Alvi to come and start the program. Like we said, Dr. Alvi, he's a director of head and neck surgery at Endeavor Health and clinical assistant professor at University of Chicago. We are very honored to have you over. Please start the program. Jazakallah khair.
Assalamu alaikum wa rahmatullahi wa barakatuh, everybody. And Jazakallah khair to the Health and Wellness Committee here at MCC for allowing Jalal and I this platform, as you mentioned, to talk about things that we're passionate about. I am a head and neck cancer surgeon, and I work at Endeavor Health, formerly North Shore University Health System in Evanston. And I'll be talking, as described, about head and neck cancer. I made most of this talk on my own, but I did ask ChatGPT to make just one quote for me. And I think it did a really nice job really capturing some of the nuances of what head and neck cancer is to the human being. So, head and neck cancer strikes at the very core of what makes us human. The ability to speak, swallow, and breathe with ease. Tumors in this region don't just threaten life, they disrupt communication, nutrition, identity, and airway function in profound ways. Each diagnosis represents not only a fight against cancer, but a fight to preserve the essential functions that connect us to the world and to one another. So ChatGPT, I hope, won't be replacing doctors anytime soon, but it may replace some writers. So what is head and neck cancer? These are, broadly speaking, cancers that start in the mouth. So the mouth we call in medicine the oral cavity. These cancers can also originate in the throat, or what's known as the pharynx, or the voice box, which we call the larynx. Some head and neck cancers actually also originate in the nose or sinus cavities or even in salivary glands. Those are a bit less common than the ones that originate in the mouth and throat, so I'll speak mostly about those. But just so people are aware, they can really affect any area above the collarbone. Cancers of the brain, the eye, the thyroid gland, the skin of the head and neck are usually not classified as head and neck cancers. The majority of the cancers that I mentioned are squamous cell carcinoma. So if you see that word around in the literature, it just really is the most common type of cancer that we diagnose in the mouth or the throat. It's relatively uncommon in the United States. Dr. Baig mentioned, many of the heavy hitters, the breast cancer, colon cancer, prostate cancer. Overall, head and neck cancer is, or only makes up about 4% of newly diagnosed cancers in the United States. And typically, it is a cancer of individuals over the age of 50. But even in head and neck cancer, we are starting to see a rise in incidence in people younger than age 50. We're seeing it more in young women as well. People who do not have traditional risk factors like the ones that I'll get into. So certainly maybe not the same drastic rise as colon cancer, for example, in young adults, but it is happening in head and neck as well. There is no established screening test for head and neck cancer. So just as we learned from Dr. Baig about all the utility and all the screening tests that are out there for colon cancer, breast cancer, prostate cancer, unfortunately for head and neck cancer, we do not have a readily available blood test or saliva test or screening examination that can accurately diagnose this. So in that case, just knowledge of symptoms, early detection, early evaluation are crucial. I'm not going to get in super detail about this anatomy, but I just want to show, even in the narrow world of head and neck cancer, how broad it can be. The oral cavity or the mouth makes up the lips, the tongue, the gums, the lining inside the cheeks, which we call the buccal mucosa, the floor of the mouth, which is the space underneath the tongue, the palate, which is the roof of the mouth. All of this can be impacted with cancer. The throat similarly has multiple parts, the oropharynx, the hypopharynx. These are parts of the throat that include the tonsils, for example. Everybody knows about tonsils being something that children get taken out for recurrent sore throats and strep throat. But as I'll mention, it actually is becoming one of the most commonly diagnosed areas of cancer in the adult population in the United States. The voice box, which we call the larynx, can also be impacted, and that's what gives us the ability to speak, to breathe, to help with our swallowing. And as you can imagine, not all of these are easily examined, not only by the patient themselves, but even during a primary care checkup with your physician. Oftentimes, these need assessment with an ear, nose, and throat physician for a more detailed and sometimes camera examination in the office. What causes head and neck cancer? So we all know that alcohol and tobacco consumption, including chewing tobacco, are the two biggest risk factors here in the United States. What we may not know is that the human papillomavirus, or HPV infection for certain throat cancers now has become the most common risk factor, specifically for cancers in the oropharynx. And HPV infection now causes over 75% of the oropharyngeal cancers in the United States. This, alhamdulillah, is not yet, and hopefully never will be, but definitely not now, a big risk factor in the Muslim population. But the virus is so prevalent that it is something that we all need to be aware of. As I list here also pan, so betel nut or quid consumption is a major risk factor for oral cavity or mouth cancer in countries in South Asia, including Pakistan and India. Prior radiation exposure, some genetic conditions, even workplace exposures can put you at risk for head and neck cancer, but this last category is a pretty rare causation. Just briefly to speak a little bit more about HPV, it is actually the most commonly sexually transmitted infection in the United States. And the reason that it is so common, it often does not cause any symptoms. So people are totally unaware of being exposed and being infected to HPV. We've known for some time that HPV infection can cause cervical cancer, for example, in women. And now we know really with research over the past few decades that it's a major risk factor for head and neck cancer in both men and women. So much so that the CDC now recommends HPV vaccination for both boys and girls, starting at age 11. And in some cases, people are eligible to get vaccinated up to age 45. And we hope, head and neck cancer specialists hope, that with routine vaccination here in the United States and in the developed world, that we see drops in the rise of this cancer in the future. but it's going to be a delayed effect. I'm going to talk about pan for a little bit. So I didn't mention at the beginning, Jalal mentioned earlier, but what also motivated me to give this talk is probably 4 to 5 times a year, I see a patient with some pretty advanced head and neck cancer from our own community, from the north side of Chicago, the Muslim north siders of Chicago. And almost always, it is secondary to pan consumption. So pan, also known as betel nut, areca nut, or supari as it's called, contains the substance called ericoline, which is carcinogenic. Carcinogenic means that it's a cancer-promoting chemical. Betel quid is actually a combination of the betel nut, lime, and sometimes tobacco. And the combination of these 3 ingredients is used often in countries in South Asia. And this dramatically, as I'll show you shortly, increases the carcinogenic or cancer-promoting properties of this substance. Studies estimate that in some countries in South Asia, 20 to 40% of adult men consume pan. And even in women, 5 to 15% will consume pan. So heavily, heavily, heavily prevalent. As I mentioned before, head and neck cancer overall in the United States is uncommon, 4% of newly diagnosed cases. But if you look at countries like Pakistan and India, head and neck cancer is actually the most prevalent cancer in men. So the first and the most commonly diagnosed cancer in men in Pakistan and India is head and neck cancer, primarily of the oral cavity. And it's highly, highly common in women as well. I took this quote out of an article that was published in the New England Journal of Medicine a few years after the pandemic, and I thought it was pretty captivating, so I'll read it. In 2022, it remains legal to sell an addictive carcinogen without a warning label in much of the world. The fibrous seed of the areca palm, most commonly known as betel nut, has been cultivated throughout the Asia-Pacific region for thousands of years. The nut is chewed but not swallowed. People use the substance for a stimulant effect that enhances alertness and in some produces a mild euphoria. Although chewing habits are highly variable, the nut is often consumed as a quid, with tobacco, slaked lime, and a plant leaf. According to frequently cited estimates, there were 600 million betel nut users worldwide in 2002, which makes ericoline from betel nut the 4th most commonly consumed drug in the world, after caffeine, nicotine, and alcohol. So you can imagine that in some parts of the world, depending where you grew up, it may be very culturally appropriate to consume pan regularly with your coffee, with your chai, sometimes even on a daily basis, without fully understanding the potential downstream and serious risks of this addiction. You can compare this to smoking, but here, manufacturers are now mandated to include a warning label, but that's still not universally the case with pan. This is a table that summarizes the risk of development of mouth cancer based on the consumption of some different drugs and products. So you can see that cigarette smoking, for example, puts people at 3 to 7 times the risk of development of mouth cancer versus non-cigarette smokers. Alcohol is 2 to 5 times the risk. Betel nut is 3 to 5 times, betel nut users are 3 to 5 times likely to, 3 to 5 times more frequent to get mouth cancer than non-betel nut users. So the risk of betel nut use in mouth cancer is actually worse than drinking alcohol. Chewing tobacco, and here's where the numbers get even more dramatic, increases your risk 8 to 15-fold versus non-chewing tobacco users. And if you're using betel quid, which is a combination, as we mentioned, of the betel nut with tobacco, that risk can get to 20 times as much as non-users. So one of the most dramatic risk factors there is the consumption of all of those ingredients in combination. So what are the symptoms of head and neck cancer? When it comes to mouth cancer or oral cavity cancer, some of the symptoms include noticing a white patch, which we call leukoplakia, and I'll show a few figures of what that is. A painful sore, painful ulcer, pain on chewing, a growth in the mouth that won't go away. These are all very concerning for the development of mouth cancer. For throat cancer, a persistent sore throat, persistent difficulty swallowing, choking on food, for example, should raise someone's suspicions. For voice box cancer, naturally somebody who develops a hoarse voice that once again doesn't go away, or at worst, some new breathing difficulty. This can also be the sign of voice box cancer. And then lastly, any lump or swelling in the neck that somebody notices that lasts beyond 2 weeks. You'll see that the main takeaway with symptoms is anything that is persistent. Everybody gets a sore throat now and then, a little ulcer on the tongue now and then that comes and goes or goes away. But I would say if any symptoms persist beyond that sort of 2 to 3 week threshold, it's likely time to at least get evaluation from your primary care, from an urgent care, and maybe ultimately a specialist. This, I think, nicely shows what leukoplakia looks like. On the surface, it doesn't really look too dangerous. You see a little white patch on the side of the tongue, a little white patch on the inside of the cheeks. Leukoplakia certainly does not mean cancer. Leukoplakia just literally means white patch. But at times, leukoplakia can be precancerous, or what we call dysplasia. And precancer is much easier to treat than cancer. So any persistent leukoplakia should likely be further evaluated. These are often picked up at routine dental screenings. Patients then usually sent to either an oral surgeon for a biopsy, or sometimes an ear, nose, and throat surgeon for a biopsy. What we want to avoid is getting to this stage, where now there's a more painful, sore, larger, it bleeds, it hurts every time you chew, it's been weeks, it's causing you to have weight loss. This almost certainly is the development of a cancer. As I mentioned, any lumps that people notice in the neck that don't go away could be the sign of what's called a lymph node. Lymph nodes are these natural things we have in the body that help within our immune system, but at times, swollen lymph nodes can be the sign of something more dangerous. Even in previous generations of medicine, people with swollen lymph nodes would often get antibiotics to see if it was an infection to go away. But now many guidelines say that any enlarged lymph node in an adult patient over 40 years of age, no matter the time course, should be treated as cancer until proven otherwise. What this means is that wherever the cancer started, in the mouth, in the throat, in the voice box, it has spread, or what we say metastasized, into a lymph node. These lymph nodes can be sometimes below the jawbone or as far down as in the neck as right above the collarbone. So the treatment for head and neck cancer, like many cancers, I'm going to be brief about the treatment. There are 3 main arms: surgery, radiation therapy, or medical therapy. Medical therapy includes chemotherapy or immune therapy, as would be prescribed by Dr. Baig. Earlier stage cancers can often be treated by one method alone, meaning sometimes surgery alone, or sometimes radiation alone. Later stage cancers often require a combination of these therapies: a big upfront surgery, followed by weeks of radiation, followed by weeks of chemotherapy. Earlier detection, as we've hit on many times today for all cancers, but particularly for head and neck as well, leads to easier and more tolerable and more functional treatments and better outcomes. Not just cancer outcomes, but even functional outcomes. I'll talk a little bit about surgery because that's my specialty, but just wanted to highlight again the radical difference that can be made in treating a cancer when it's early versus late stage. So surgery for head and neck cancer often includes not just removal of the diseased tissue, but also reconstruction. Again, not to get too complex, but glossectomy is the word that we use for removal of a tongue cancer, which is one of the most common types of mouth cancer. If somebody has a nice, small, early diagnosed tongue cancer, they can get away with something called a partial glossectomy, which is, as it sounds, is just partial removal of a small portion of the tongue. And in these patients, I can counsel them that you likely will have very functional swallowing, very functional speaking after your recovery. But it can get more extreme from there. You can have a hemiglossectomy, which is removal of half of the tongue, or even what's called a total glossectomy, which I've unfortunately had to do many times. This is when a cancer diagnosis is so delayed that the majority of the tongue is involved in a cancer. And you can imagine, by removing somebody's tongue and having to rebuild that, that patient will have dire consequences for their long-term speaking, swallowing, and nutrition. Aside from function, the stage of the cancer also impacts what we call prognosis. So prognosis just means for all cancers, how likely is the patient or the individual to be cancer-free at a certain time period in the future. In medicine and oncology, we often use 2-year survival and 5-year survival. A lot of our numbers are based on that. So this graphic is simply showing the difference in survival for mouth cancers between stages 1 and 4. And I'll just show that in the pink line for stage 1 early diagnosed cancers, survival at 24 months or 2 years after treatment is roughly 85 to 90%. So pretty good. It's not 100%, but still, fairly good odds of being cancer-free 2 years out. When you go to stage 4, you can see how dramatic of a drop in survival and prognosis you have in head and neck cancer. You go roughly to 50%. So it's a very, very tough conversation for me when I meet these patients with these advanced cancers, that we're going to go through all this treatment that's going to change your life, and at the end of the day, we still have a 50-50 shot. So our goal is still to try and get people diagnosed as early as possible. So how can I reduce my risk of developing head and neck cancer? One, of course, is education, what we're doing here today. Just being aware and cognizant as a patient, as a physician, I think there's some in the crowd, about what we should look for in people. Of course, stopping any of the risk factors. So tobacco, pan, alcohol consumption, primarily the tobacco and pan probably in our community. Stopping those can make a dramatic effect in decreasing the cancer rates. HPV vaccination, as I mentioned, this is not as relevant likely to the Muslim population, but it may be in the future. And again, as I mentioned, it is a guideline now by the CDC to get both boys and girls vaccinated. And the whole reason they started including boys was for the prevention of this cancer. And then regular dental examinations. This is so key because dentists, as we'll learn about shortly, they can pick up on these early leukoplakias, early tongue cancers, and get them into the right people for a biopsy. So regular dental examinations in the absence of any screening is huge. These are just some resources that I'll list. A lot of this talk was basic material taken from the NIH cancer website. They have a whole fact sheet about head and neck cancer. As I mentioned, I work at Endeavor Health, and we have cancer clinics at Swedish, near a lot of the Muslim community. I work in the clinic in Evanston and have a lot of patients there as well, but there's sites throughout the North Shore area. And this is my email. Oftentimes when somebody in the community does get in head and neck cancer, unfortunately I get approached, even if it's just for counseling, even if they're getting treated somewhere else, I'm always happy to talk. So that's my information there. And that's it. Thanks for your attention.
MashaAllah, Jazak Allah khair. Thank you so much for a beautiful and very important, pertinent topic to our community. Appreciate that, Dr. Alvi. Thank you so much for that. If anyone has any other questions, please pass on the note cards, then we can start doing the question Q&A. First question is overcoming barriers such as healthcare access. What can communities like ours do to improve overcoming barriers?
Yeah, I think I'll probably just go back to the hadith we talked about, that your body has a right over you. I think that's very relevant, especially for people that are reluctant to get cancer screenings in our community. I think a lot of this is based on faith-based messaging. And we go back to that study that I highlighted about that was done by Dr. Padilla, which used peer educators, so people that have credibility and currency with the community. I think having those people involved in having discussions like this, so peer educators, physicians, religious scholars, community health workers, I think just having as many discussions as we can to overcome that religious or cultural barrier that a lot of people perceive, I think will be helpful. In terms of insurance and access, I think there are a lot of other layers and a lot of other individuals that can help with that. But I think to overcome the cultural and religious barriers which are most relevant to us, that's probably the best approach. So hopefully, inshallah, more conversations like this going forward with relevant people and strong audiences.
Jazakallah khair. Thank you so much. The second question is, I have a note card with 3 pointers on that one. First one is, all cancers have the same signs and symptoms. Example, breast, colon, lung, neck, head and prostate cancers. How do you clean gut? And the third pointer is dense breasts, I don't know.
So the signs and symptoms of a cancer are all going to be specific to where the cancer is occurring. So if I can give you a few examples, breast cancer would be some kind of mass or lump in the breast, most likely, and then you're going to be looking under the armpit area, the axillary area, if you feel these lymph nodes. Dr. Alvi spoke about these lymph nodes, which are these ball-sized swellings. So breast cancer symptoms will be similar to those, especially when the breast cancer is still localized. Colon cancer is going to be more related to your GI system, whether that's blood in the stool, changes in weight, nausea, vomiting, pain after eating. Lung is going to be more related to your breathing, so shortness of breath, you have a new cough. Head and neck, Dr. Alvi spoke about that at length, the kind of symptoms that you're looking for. And then prostate can be related to difficulty urinating, blood in the urine. So the symptoms will always be related to the organ. All the symptoms won't be the same. There's some symptoms that might be similar at the end, like if a cancer's progressed for a long period of time, then you may have weight loss. If it's some kind of GI cancer that's progressed for a while, then you might have difficulty with nausea, vomiting, changes in your stool. But always look for specific symptoms to that organ system. Dense breasts, mammograms, which are just x-rays of the breast, are not always effective for dense breasts, so using ultrasounds and MRIs. Those are probably the best imaging tests. But when you get the when you get the mammogram, the radiologist will read that this is a dense breast, we need to get an ultrasound, or we need further imaging with an MRI. They will let you know about that. But it's good to be aware that dense breasts are not easily evaluated by a mammogram, which is a simple x-ray. How do you clean your gut? I think that might be a relevant question for someone who's getting a colonoscopy in terms of preps and the like. Unfortunately, the GI part of it is beyond my pay grade, so I can't really comment on the types of preps that exist, because I know there's some new solutions that exist that are far easier for patients, but that's something that can be easily discussed with your GI doctor. They can talk to you about not only other alternatives to colonoscopies, but the different types of preps that exist to help you cleanse. And it's important that you cleanse, because if you don't cleanse well, you're going to get a repeat colonoscopy probably within a couple months. So you want to clean your gut as well as possible.
Jazakallah khair. We can use this mic, you guys. The next question probably is for Dr. Alvi. The question is, if there are lumps growing in instance on the skull in size over time, but doctors denies it, could be cancerous.
I wasn't able to tell if it's at skull or skin. Is that skull? Skull? Okay, yeah. So the skull is not often a site of concerning lymph nodes. There are some lymph nodes behind the bottom of the skull, what we call the occipital lymph nodes, and some below that. But if there are lumps on the skull itself, like on the top of the head, those would not be lymph nodes. Every now and then I will get a referral for a patient with some sort of growth on the scalp. It could be a skin condition. Sometimes people have just non-cancerous sort of cysts on the skin of the scalp. Every now and then there are actually some growths that can happen in the bone of the skull itself. From what I know, most of those tend to be non-cancerous as well, something we call osteomas. So in general, what I will say is, like Jalal mentioned earlier, advocate, for yourself. So if it is truly something that you're very concerned about, the primary care physician, as this note mentions, has been dismissive of it, maybe you could suggest getting some imaging, sometimes even a basic ultrasound if they don't want to do a CT scan. Or ultimately, these days, it's pretty easy to just get yourself in with the specialist as well. A lot of self-scheduling and, asking for referrals. But again, to answer the initial question about on the skull, that most often is not concerning, but again, advocate for yourself.
Thank you so much, Jazak Allah for the input. Next question is also for you, Dr. Alvi, I believe. The question is, what triggers throat cancer for a person who have no history of consuming the items that you listed and no family history of that cancer?
Yeah, that's a great question. So always in cancer, there are rules and there are exceptions to the rules. So from time to time, I will encounter a patient with throat cancer who's a non-smoker, non-drinker, no concern for HPV infection. And as we know, as we believe that, Allah subhanahu wa ta'ala has control of all of these things. So unfortunately, there are times where we don't have an explanation, and that does make it challenging. Just recently, actually, I met a woman who's an immigrant from Turkey. I don't think she's in this community specifically, but I saw her for a new diagnosis of throat cancer. And she, of course, has no history of smoking, no history of drinking, but for some of the doctors in the crowd, you may remember from your USMLE, she actually has a diagnosis of something called Plummer-Vinson syndrome, which is, it's the first and probably last time I'll see it in my career, but these patients, because of that condition, are predisposed to developing throat cancers, and it's an incredibly rare condition. So regardless, to answer the question, sometimes we don't know. Sometimes, as these things are not in our control, as we know, but you just go from there and do what you can to diagnose and treat and pray and move on.
MashaAllah, very nice insight to that one. The next question what we have is probably Dr. Jalal can take it. What are the earliest symptoms of cancer? Do you think it is our food or preservatives in the food that is blamed for increase of cancer?
Yeah, so in terms of the earliest symptoms of cancer, again, like we discussed in just the previous question, the symptoms are going to be very specific to where that cancer is occurring. So if in your lungs, it's going to be the shortness of breath and a cough. It's the breast, it's going to be a mass in the breast or a lymph node under the armpit. If it's a head and neck cancer, like Dr. Alvi spoke about, it's going to be pain or some kind of swelling or bleeding in the mouth. So it's always going to be very relevant. It's going to be pertinent to where that cancer is occurring. And if that symptom is persisting beyond a week or 2 weeks, that's when you know you have to probably get it checked out. So if something is persisting for more than a couple of weeks, and you're noticing some lymph nodes, some lumps or bumps in the neck that Dr. Alvi also spoke about, then you know that maybe that's something worth getting checked. So if the abdominal pain is persisting for 3 to 4 weeks, if the shortness of breath is persisting for 3 to 4 weeks, it's probably good to see a primary care doctor, consider getting a colonoscopy, consider getting at least an X-ray or a CT scan. One of the red flags or concerning symptoms we always talk about are weight loss. So if you have unexpected involuntary weight loss, so if you're not dieting and you're not exercising and you're suddenly losing 5, 10, 15, 20 pounds in a short period of time, that is a very general symptom that might be alarming, that might be the sign of something going on in the body, like a cancer. So unexpected weight loss, in addition to everything we just spoke about. The other question is, you think it's our food, our preservatives in our food? Absolutely. I think we're still working on figuring out these early onset cancers and what's causing them specifically, but I think these ultra processed foods and preservatives are a major culprit, because a lot of these early onset cancers we're seeing, whether it's colon cancers, pancreatic cancers, biliary cancers, stomach cancers, all of these processed foods are obviously traveling through the digestive tract. So all of these carcinogens that exist, and you see it all the time, that so-and-so preservative in this food was isolated and identified to be a carcinogen. And this food has been on the market for years, has been on the shelves in grocery stores. So it's honestly really frightening. My wife sends me these all the time to guilt me about the things that I eat or drink and consume. So we're all guilty of it, because these things are ubiquitous. But absolutely, these ultra-processed foods and preservatives, I'm sure, are a huge culprit.
MashaAllah, very well explained, Dr. Jalal. Another follow-up question on that is, now we have been using all those processed food, frozen, stored in the fridge. Most of them we use microwaves to warm up those foods. What are your thoughts on those using microwave food?
I've looked into this. I've had uncles and aunties tell me that they make fresh food every day because they never want to microwave food. I can visualize them in my head, because you don't forget those people. But I don't know of any cancer associations with microwave use. I've looked into this. I've Googled it. I didn't find anything. No, but in all honesty, I haven't noticed anything.
Okay, Jazak Allah. Thank you so much.
Feel free to warm your food. Cold food is not comfortable.
So next question is, I think this is a very valid question. I see these patients in my practice also coming to my office very late. The question is, any screening available for ovarian cancer? The second question on this one is, incidence of non-smoker lung cancer rising. Any causes for that?
So ovarian cancer, so a lot of cancers, unfortunately, that don't have established screening modalities. Pancreatic cancer is one of them, stomach cancer is one of them, ovarian cancer is one of them. And unfortunately, ovarian cancer is one of those cancers that you don't actually get symptoms until the cancer has progressed. So you have bloating, you have unexpected weight loss, pelvic pain, and especially when those symptoms begin, that's when it's probably progressed to a stage 3 or a stage 4. So the succinct answer to your question is no, there's no screening that exists. Some people will get ultrasounds, perhaps, these pelvic ultrasounds. But that's always between you and your gynecologist, or between the patient and the primary care doctor.